I'd introduce our guest speaker, Janet McKee. Janet has a lot of initials behind her name. MS, RDN, CSG, LD/N, DAPWCA. Wow. She's the president and owner of Nutritious Lifestyles, a group of about 85 RDs, LDs, DTRs, and CDMs that provide nutrition and food service consultation throughout the U.S. Janet has a BS degree in home economics education, an MS degree in nutrition, food service, and institutional management. And if you ever want to see a grown surveyor turn into mush and ground up, have her do a IDR for you. I've used her I've known Janet for about 11 years now. Use her services many times. Excellent, provides excellent service, not just for routine stuff, but also to just get into a bad survey situation with a crazy surveyor. She will take care of it. That's a little more than the introduction. But at this point, I'd like to turn it over to our guest speaker, Janet McKee.
I'm just going to get out in the masses so I can really talk to you because we have a small group here, so we can make it much more intimate. So the purpose of this talk today is to talk about how nutrition can set your program apart, but also to talk about the continuum of care, how in the future that we will have to start doing nutrition discharge planning for people that have a lot of admissions, and admissions go back into the community. It will be necessary to have positive outcomes because they'll be tracked. So that's really what we're going to be focusing on. There is definitely a link between nutrition and rehab status. And if you think about it, if you didn't eat food for 24 hours, what happens to you?
Get hungry.
You get hungry. What happens to your brain, which is the only organ that's completely dependent on glucose? What happens to the brain cells? They start slowing down, but then you also start breaking down your lean body mass when you don't eat well, which is your heart muscle, your leg muscles, your calf muscles, your biceps, your triceps, because you have to have glucose to feed the brain. If you don't have adequate glucose coming in and protein to rebuild, you won't have the optimal outcomes. And if we look further and further into rehab, that will be becoming more and more important. Poor nutrition hydration status, and there's been quite a few studies. One was done by Kaiser Permanente. They have had many nursing home and many hospital continuum of care studies that indicate that when someone leaves the hospital or nursing home, if they're given rehabilitation nutrition guidelines to go home with, that they have better outcomes than those that do not. Their purpose was primarily cost control because of their situation of the continuum of care. It's all in their pocketbook. They've been able to reduce the recidivism from the community to the hospital by providing these triage discharge nutrition plans a lot. So here are our patients. Back when I started, which was much longer than I've known Edwin, our patients were very old, really and truly. When I first went into like Florida Living, they looked absolutely ancient. Of course, I was very young at the time, and so things are very perspective now. But they were very elderly patients. But now when I walk in one of my clients, that's not really true anymore. Especially if you look at pockets that are resort areas, like the Lady Lake area and the Ocala area and even the Orlando area. We have a lot of people that came down here in their 50s to play golf. They have different expectations than you do or your elderly nursing home client, and so they don't look like a typical nursing home client. And let me tell you, because we do business in 18 states, and one thing that's a common denominator is I can tell you, it doesn't matter if you're in the Panhandle of Florida, or if you are in Georgia, or if you're in Texas. People or baby boomers have higher expectations for food, and they are not happy with 3 meals a day on a tray. And so as we start thinking about changing the way that we're going to do business in the future, I suggest you start thinking about moving away from a tray line because it's not customer service oriented. So when we take these patients, and I was just in Pinehurst, North Carolina about 2 weeks ago, and I went into one of our facilities there, And there had been a lady that was our client, and she went to the hospital for a month. She got a UTI, and the UTI, for whatever reason, was not treated. It wasn't effective, the treatment, and so it became a septic situation. So she went into the hospital, and she lost 42 pounds in 1 month. So she came back to us. She was malnourished, even though she was very overweight, because there is a thing called sarcopenic obesity. You cannot look at someone on the outside and assume they're well, because they're not. She came in and she was very ill. She could not even pick up a fork to feed herself. So we take debilitated clients all the time. Sometimes they leave us and go out to the hospital. Sometimes they come into us coming from the community or hospital like that. But I think that it's important to have strong nutrition for rehabilitation, for outcomes, because if you think about it, to walk that 100 feet that the PT is going to require that they do as their discharge plan, it takes a lot of protein and calories to maintain the energy to do that. So it's important when you have people that have surgical wounds, and yes, even hip replacements, because a hip replacement would require at least 10% more calories. And what's more important, did you know after age 65, that, and some of you are probably age 65, that you need a lot more protein yourself, because as you age, hormonal status causes you to lose lean body mass. It's part of aging. You can retard that yourself by upping your protein and upping your exercise, but typically rehab clients don't know that, and so we should really be focusing on the protein. So a lot of clients that we get are closed head injury, and a lot of people are with us to rehab after having an MI for the hospital. I know one of the facilities actually has, when a person has a heart attack, they leave, they stay in the hospital sometimes 72 hours, they go into a rehabilitation center for PT and rehab, and nutrition should be part of the training they're getting, and then they go back home. And the average length of stay at this unit in Sarasota is only 20 days. So our market has really changed. So people need extra calories in rehab and extra protein, and all calories are not created equal. And I brought some samples of that. And you can pass these around, and at the end, whoever wants them is welcome to have them. So read the label. You can't read that label because it doesn't have one. Here's a more medicinal product. I'm going to pass that back to you. But the bottom line is these people need protein and a lot of it. And you have to really think about how you're going to get it in them because of other problems that will come up that we'll be discussing. So they typically need a lot more fluids, they need more calories, and they need protein, especially in the initial rehabilitation. And then your goal for every one of your residents should be, if they're a normal weight, which means above 120 for a female and 150 for a male, you want them eating 75% of your meals. I guarantee you it's not happening. And you really, if it's not, you ought to be doing plate waste studies in your kitchen, because it's either the menu or the food, or they just don't feel like eating, and those are all problems. Food is the second highest cost in a nursing facility. And it's a sad thing because I was in Texas 3 weeks ago at an office, and I went out with one of the RVPOs to a nursing facility in the Dallas-Fort Worth area, and I asked her, could I look at the dining room? And when I did, I went in there, I was absolutely shocked at how many of their puree diets came back. And when I tasted them, I know why. Because they did not follow the recipe, and the pureed peas had so much of the starch, the powdered starch in them, they were shining enough you could almost see your reflection in them. So it tasted like starch. And that was the same building, and that building I haven't started there yet, but I was told the last survey, the cook actually told the surveyor, I don't know how to follow a recipe, I've never seen one. So that will require a lot of training and work. But really, all us need to put our focus on the resident. What do they want? And the traditional menu that we've been serving, honestly, it just doesn't cut it anymore. In America today, the Hispanic population is booming. And their food dialect, even though in states like Texas it's been very common, even in Orlando, there is a nursing home in Central Florida now that has 38 Hispanic patients. Grits, collard greens is not going to cut it there. So we have to figure out different ways to serve everybody. In fact, Reinhardt Foods is starting with a 12 always available menu at lunch and dinner. They're not even going to have a regular food. They're not going to have a menu. You're going to have a 12 always available. And I see that as many changing waves of the future. But it really is what the client can accept and really what they want. So I wanted to take this opportunity to educate you about some changing things that are happening. There are the young. Anybody under 55, I just passed that milestone last year, is considered young these days. When I was 30, I thought somebody 45 was practically needing to be, in a grave. But things change and respective. And then there's the old. The old is 65 to 75. The old, just the plain old, are 75 to 85. The old are 85 and greater. Now, what do you think the highest parameter of growth in geriatrics is in the United States? 85 plus. So that's a good thing for the nursing home industry, but it also makes it really hard because those people are the great World War II people and they would be happy with the tray line. Here's the thing, I trust you, my phone rings off the hook with the 55-year-olds that are not. We have to start thinking outside the box. How can we deliver a menu that meets everybody's needs because their needs are so much higher than a general person? So they need more calories, more fiber, more protein and fluids, but how do we get it in them? Well, let's talk about that. Then we have the confrontation of pain because no one I know, including myself, I learned my lesson. The first time I had a C-section, I said, oh, I don't need those pain pills. Second time around, I said, sign me up. But they have negative contraindications. There isn't a pain medicine out there that does not have a negative effect on appetite at some level. Also bowel motility. So how do you make your meals when you have this problem going into it taste better? You use flavor enhancers. For example, if you make cornbread, unless you're in an area that won't tolerate it, why don't make your cornbread like a cake? Sweeter, more protein, more calories. And we'll be talking about that a little bit as we go along. But I brought something, I wanted to give you some ideas of something I'm trialing. And if you put your business card in that white bag, you get a chance to raffle these. There's a candle maker that I have met recently. I have another one too. And she calls herself a candle aromatherapist. So if you smell these, and then here's another one, it's called a refresher. And then we also are raffling off this, anybody wants to get this. She made this in honor of the people that were murdered at the Pulse in Orlando. It's pretty cool. So when we're looking at these, how can we make people really want to eat? Well, I can tell you that when I was in that tray line in Texas, I don't blame those people for not wanting the food because here's what the green beans look like. They came right out of a number 10 can. They had strings in them. The food that they had on the meat was a meatloaf. They also had not followed the recipe on that, and I could see great big old hunks of bread in it like that, loaf bread. So they didn't follow the recipe, but even if the food had looked great, there might be some people that aren't feeling like eating. But how can we change that? Well, we need to realize that people, particularly those people 75 and older, they have lost their olfactory bulbs. After age 65, they start to decline. And did you know that 80% of your taste ability is in your nose? Well, I met a doctor at a presentation that I was giving for dietitians, and I got to know a little bit about that field, and it was quite interesting. Statistically, your food will taste better to those people if you wake up their taste buds. How do you do that? I brought a candle because that was something you could handle and get a kinetic feel for it. But you can use potpourri. You can go to any store in the United States, including Walgreens, and you get paper rings that have different food smells on there. So what you want to use is vanilla, cinnamon, pumpkin spice, Christmas tree, and cookie smells, cookie dough. If you put those in the rings in your dining room, it's a low-cost thing to turn your dining room into a positive experience, and people will eat better. Now, I took that little tube that you have, and that is to stimulate the taste buds. Now, she's developing a cinnamon for me, and that one is one that she had, but she's developing a cinnamon. And so if you have someone that's going to eat in their room, that's a good thing to use for them to get them stimulating. And they're only $4 a piece, so it's not very much money. So I think that we have to look at everyone as a human being, and you can see that nutrition needs differ. So if you have a pen and a paper, just to show you that now, there is a difference between males and females. We know that going into our metabolism classes that you all had in high school. But a male needs 15 calories per pound of weight. So you can calculate the actual number of calories that your body needs. Females need 12 times their weight. So all of us are very different. And we're very, very unique individuals. So it makes a difference, the needs that you have, because someone that weighs over 220 pounds that's a male, they cannot meet their needs on a typical nursing home menu that has 2,000 calories. They need to have increased protein loads. So you really have to understand what your population's looking like. So your stroke victims, they many times, like this lady that I personally went to see, she had lost so much weight in the hospital. I could look at her forearm and see the wasting. I also, and you should have your dietitians that you all work with, ask them, are they doing this? They should be shaking someone's hand on admission when they go see them. And if that person cannot hold your hand and squeeze it back for 5 seconds, what do you think that might tell you? Yes, because the intercostal muscle in between your fingers is the first muscle to go. So, and we always forget about that because nutrition is really not something that we all think about. But it's work for those people to eat. It really is. So it takes work to hold a fork correctly and tightly. That's why if you remember back when your kids were little, it's about 2 before they can even hold the fork correctly. And we all remember how that goes with more food on the floor than in the mouth. So they do need increased calorie and protein needs, but it's challenging to get them. So what you may not know, though, is when you have a stroke or any kind of brain accident at any point in your life, you have to have a maximum amount of protein to regenerate that. And I just prepared for this talk, and I wanted to bring it to your attention that some physicians are now using fish oil to increase for rehab purposes, and they are able to have better neurological responses based on the consumption of high protein and high fish oil antioxidant diets. So what that means is more fresh fruits and vegetables. Doesn't have to be expensive ones. It can be frozen blueberries. It can be foods that are high in fish oil, such as a tuna, salmon, and it can be a salmon salad on top of lettuce. But many people are choosing to give fish oil pills now because the research is fairly dynamic about the reduction in cardiovascular issues, because you can give somebody good nutrition, but those fish oil and the high antioxidant diet have a calming effect on the body and allow your people that are truly sick to use the nutrition more effectively. So stroke victims in rehab they're really high risk, because if you think about someone that has dysphagia, they might be only able to eat a tablespoon at the time. Because if they were in the hospital and they had a stroke prior to that, they're in there a week, we do a great job at feeding people in long-term care. I have hospital clients in LTACs. They do not have assigned CNAs just to feed people because their people come in and out, in and out, in and out. So a lot of times if they eat 20%, they just take the tray. So those people really need a strong nutrition plan to rehab. So when you get them, it's kind of our chance to shine because we have them many times for rehab up to 20 days. What can we do to make a difference in their lives and to build them up stronger? Many of your physical therapy departments are now doing calf circumference, and they're also doing quadricep circumference and hand strength parameters. There's it's called a diameter. You squeeze it, and the goal is to get them stronger. And so that really works really well with the high protein diet. So your risk factors of dysphagia, I reviewed some care plans from my staff 2 weeks ago to prepare for this. And what I looked at is the timing that ST had said, how long it would take. And then I counted the tablespoons on a tray, a typical tray. And it was a lot of tablespoons. And if they could only swallow a tablespoon at the time of mashed potatoes, it would take 12 minutes to feed them the mashed potatoes alone. So that means that when you have someone like that, they are so at risk because it takes a long time for them to swallow. Maybe that's the kind of client you should look at fortifying the potatoes. Maybe that would be a client that you want to fortify their puddings. And it's very easy to do that. Instead of using regular milk with your potatoes, use half and half. You add for a cup, you add an extra scoop of dried milk. Therefore, the potatoes have 450 calories and 12 grams of protein. So if they only eat 2 bites of the meat, they drink their chocolate milk, then they've met the majority of their needs right there in a small amount. So we have to think outside the box. Some of the people that I get are on 12 and 13 medications. The majority of those cause in the elderly dry mouth syndrome. So it's harder for them to swallow. So you have to think about making their food more palatable and lots of gravies. And eating difficulties are abound because when you lose muscle mass in the hospital and it happens with illness, you're not many times going to have the strength to feed yourself a 45-minute meal. So we have to think outside the box, and how can we do that? Well, they're fatigued, but could we use some foods that are higher in protein but finger foods? For example, you can make small biscuits like that. You can, instead of using water, you can use powdered milk and cream to make them, and you can get a lot of calories in a small biscuit that they can pick up. It takes a lot less effort to pick up a biscuit or a high-protein brownie and a chocolate milk for a snack that they can do themselves than it does to try to eat a meal that they have to cut up and serve themselves. It requires strength to eat. So if you think about it, and now everybody just chew. You chew very normally, but let's think if you had lost 30% of your weight, as this lady did that was in Pinehurst. Her chewing skills are a lot less, and definitely her swallowing skills. Because I looked at her throat, and her throat, her skin on it, you could almost pull it because she had lost so much lean body mass. So when you look at people's throats, and they have like that chicken throat, not necessarily just from old age, but from not having that, because this is a voluntary muscle. And when you lose a lot of weight, we don't think about it, but this muscle weakens. So it's more difficult for them to eat. So it's important that everybody be on the same page. It's important that even if you have a great RD and she assesses your needs, they have to tie into what the other rehab people are doing. And I was just thinking about this when I was preparing for this. You know, we have all these people going into rehab. Sometimes they're going in groups. But why aren't we having like a special coffee there after rehab to give them a chance? Because after you work out, you get to drink Gatorade, right, to refuel your muscles. But nobody does that for them because I don't think we think about it. So we should really be offering like a chocolate milk, which is not very expensive, and a treat after they finish to refuel their muscles. Because when you're rehabbing and their PT is making you walk down that hall, it's exhausting to the muscles. They use up all their glucose. If you replenish that with protein and hydration and food and protein, it immediately feeds that muscle so it can pump up, which is exactly what you want. So it's important when you're looking at especially rehab, you really should be working with your dietary manager. The dish room should be your place that you as an administrator check on. Because if you have more than 30% coming back off your trays, you've got a problem. You're basically go to the toilet and flushing dollars down every day. One example of that, if a woman comes in your facility and you take that rule of thumb, and it works for everyone just about, and she weighs 90 pounds, she cannot possibly eat the 2,000 to 2,400 calories on your tray. So think outside the box and consider putting that person on the regular meat portions, milk portions, but do they really need as much starch as on the plate? They don't. It's overwhelming to them. And so you really should think about how to get more power in the punch. And people really ought to be getting what they eat. What's wrong with fried chicken? Nothing as far as I'm concerned. We should develop our menus, and really and truly, the menus from generic companies, US Foods, Gordon's, all the different companies, they have menus. But do they really reflect your residents' needs at your facility? A lot of times they don't, because people in the panhandle, they want bacon with their green beans. And when you go to Texas, they wanted hot peppers with theirs. So you really have to take those recipes and you have to work with the food service department on customizing them. And then in different parts of Florida, we have a lot of eclectic populations. We have Cuban, we have Jewish, we have Spanish, we have lots and lots, we have Haitian. And we need to have menu items that are going to accommodate their needs. And honestly, I think the day of slapping out a US Foods menu that has baked chicken, green beans, and mashed potatoes every day is done. I think we have to do more to meet our residents' needs. And I think Diane Hall and Karen Goldsmith are talking about this today, but really and truly, 95% of your residents should be on as close to regular as possible, with exception of consistency. So you really want to look at not spending your money on diet this and diet that, but to give them a higher quality protein that they actually want to eat. So feeding support is necessary. This is a big, big thing for rehab now, because these people look normal, and many times they can look normal, but maybe they went to the hospital and they spent just 3 days, but they got a hip replacement. You know, they need a lot more protein. Post 65, they need 1.5 grams per kilogram of body weight. You need 0.8. There's nobody in this room that needs more than 0.8 grams per kilogram. So what does that tell you? That you should be talking with the staff in your facility and determining if your menu for those rehab clients has a minimum of 100 grams of protein a day. And is it in a form that they will tolerate and actually eat? And you should be doing a test tray as administrator, because you should be testing out your own food. So they need a lot of protein. And if you think about it, that PT goal of 100 feet, it's a very important goal. And they need that protein, because when they were in that hospital laying down and they were sedentary for 3 days, and this is no joke, after 65, when you're sedentary for 24 hours, you immediately start to lose lean body mass at a very accelerated rate. There's a study that they put some elderly people, 65, 75, etc., in a room, and they made them sedentary. And they did not feed them very much of a diet for 24 hours. They took 18 to 20, it was done at the University of Florida in Gainesville. They took some students, 18 to 22, they put them in another study hall. They also treated them the same way. The elderly people lost, and this is really shocking even to me as a dietitian, 325% more lean body mass was lost after the first 24 hours of sedentary activity and no food than the younger people. So hormonally, our residents are sensitive to depreciations in lean body mass. We need to do the rehab to help them build back up, but we need to give them the fuel to do that. The fuel should be high protein, high calorie diet for rehab. And it should be really customized. If someone wants a grilled cheese sandwich, great, give it to them. If that's all they want, great, give it to them. But complement their meal with other things that they might really like, such as a vegetable or a fruit. Or if they're not eating that well at the rest of the meals, maybe you need to increase their calories and their protein at breakfast, especially someone that has dementia. They eat much better in the morning. So really we need to think about what people need. When you have orthopedic clients, if you put them on a high protein diet and you ensure that they're getting adequate vitamin C and zinc, and every body part requires adequate vitamin C and zinc. So if you cut yourself and you look at the scab, the brown tissues that go across are collagen and fibroblasts. Those fibroblasts, they cannot develop without adequate protein. So if you want your residents to heal and walk faster, rehab faster, and swallow faster, high protein is really the key. Now, you are going to have the rule of thumb is if someone is not eating at least 75%, they need to be on a multivitamin that has 100% of the RDI for vitamin C and also 100% of the RDI for zinc. So you're looking at like a Theragram M. So for rehabilitation, your rehab clients, these are the sickest of the sick. And I'm going to use that lady I saw in Pinehurst. I mean, when I was talking to the dietitian that works with me there, she said this woman was doing great. She had been there, she'd lived there. She was a Medicaid patient there. Then she got this UTI. She went to the hospital. She lost all this weight and she came back with an albumin of 1.9. The normal is 3.5. So she had a very low protein level in her blood. She had lost 42 pounds, which was about 25 to 30% of her weight. She could not pick up a fork by herself. So what happened was we put her on a high protein finger food diet. She was assigned to go to rehab therapy, occupational, and it was slow. So she had to be on pureed at first. But we were able to take the pureed cookies and things and we poured milk over them and juice to make them soft and she could spoon them up. Within 2 weeks, she was able to start eating herself again, but she worked, the dietitian and the therapist, they worked very closely together. To rebuild her muscle task, she had a squeeze bottle. It's a flexible water bottle with a pointed top, and she squeezed it between meals. And they monitored that, and she had a positive outcome. Now, she's not the same as she was before she went to the hospital, but she's a lot better. She's able to feed herself now, and it took 6 weeks of staying on top of it. She's slowly gaining weight. Her muscles in her hands are much better. Her swallowing function is better, and she is back on a regular diet. She will not be coming home because she's not that kind of client, but think of the effect that would have on people that you want to go home. So rehabilitation, they're at high risk. As you get to be older, and after 65 years age, the way your brain chemistry works, the sensitivity area in your brain that alerts you of needing to drink starts to fail, and so do your kidneys. So your kidneys are supposed to know when your electrolytes are changing. They're supposed to send a message to the brain. Unfortunately, what happens is there's a misfire. It takes them 24 hours longer to know that they need to drink. So they need constant reminders to drink, drink, drink. The #1 admission for the elderly in the state of Florida to the hospital from nursing homes in the community is dehydration. So eating well is very key. There are many patients that came in like this lady that was in Pinehurst, Manor Care Pinehurst. She came in and she was really, really in poor shape. She had lost so much weight. In between her fingers, it looked like a valley. When you look at their hands, they should be flat here, but hers looked like little rivers running between her fingers. So what that told us was that she would in no shape or form until she was able to rebuild through occupational therapy, she wouldn't be able to feed herself. in time that happened. But she was one of those people that we had to fortify her food. And at one point, even after an hour of feeding, she was exhausted the first week. So we put her on fortified oatmeal, but she could eat that because she was tired. So what we did is, and I usually recommend supplements as the absolute last alternative, but we did put her on Carnation Instant Breakfast and milkshakes in between meals, and we put them in the soft squeeze bottle. And we worked very closely with OT because that helped increase that muscle strength. So, and if you look at that, that's very normal for you. But if you lost 30% of your weight, I guarantee you that you're not going to be able to grip as well. And it takes a longer time for them to rehab and a lot more attention. And there are lots and lots of supplements that people, when they're not eating well, but I discourage the use of those. Use food first and fortify it because you have your staff giving it. It wastes your labor time to be in cost center. And let's face it, nobody's going to drink 3 Ensures a day. It's going to end up on the shelf, the marble shelf in the window. I wish I had $1 for every time I'd seen a shelf. So providing support at meals, but how can we make meals more appetizing? I mean, how much time and effort and money does it really take to use a scent ring? Not much. You've got to have your dining room tables. You can make them look nice. You can work with activities on making it fun. And that when your residents are in there, it should be a very relaxing atmosphere. This is happening more and more because we don't really have any place to put traumatic brain injuries. They can't go home until they're ready. So they come out of the hospital, and of course we know that they barely get in the hospital maybe 5 days. And if they don't go to an LTAC, they come to you. Now, with those people that have traumatic brain injury, for whatever reason, the first 30 days after that traumatic brain injury, their metabolism is about 200% more. So they need mega calories, and they need mega protein. These are the people that the studies show that have brain injury and spinal cord injury that have had the most benefit from using fish oil supplements. So nutritional deficits such as not having enough thiamine can disrupt the brain function, and they already have struggled enough. A lot of times it affects their appetite center, and they actually need to be looked at from top to bottom by the dietitian, the occupational therapist. A lot of times, depending on where the damage was, if the damage was high enough, they've lost their ability to swallow effectively. So you have to look at all those parameters. And a lot of times they have feeding problems because they can't hold a fork, and how are they going to do that? So depending on where the injury is, they need customized care, and sometimes they need to have enteral feedings at night. And that is the absolute last thing that they want, and it's the last thing that we want. But sometimes, like that lady, if she hadn't been able to pick up 1,200 or 1,500 calories through her diet a day, we would have been best served by giving her feeding at night and continue to feed her during the day. So when you're looking at people like spinal cord victims and traumatic brain injury, their calorie needs to go up the first 30 days. But as you go along, something shifts. So many of them in the brain, the centers of the brain, there's the emotional side, there's the appetite center, there's the feeling center, all these different centers that we all learned about in the 7th grade on the little graph. So, but what we didn't learn is that things change as you go through rehab. So the first 30 days of a traumatic brain injury or a spinal cord injury, they have a very high need for kinetic energy. They're focusing on trying to rebuild that neurological tissue. It takes a lot of energy. As we go along, though, there's a shift. Their metabolism decreases, but their protein needs were not. So many of them, because they're sedentary, they need a lot of protein to rehab, but they might not need but 1,500 calories. Here's the problem, is that some of those people, their appetite has a push down button by psychotropics. Almost all your psychotropics, after long-term use, it's like putting your thumb down on your appetite center. And it pushes them to eat, and they develop polyphagia, which means they want to eat all the time. And I recently talked to a dietitian I know in Washington State, and she had a traumatic brain injury patient that weighed almost 300 pounds, and he literally outgrew his wheelchair because he wanted to eat morning, noon, and night. And so they were working out, trying to work with behavior therapy to give him lower calorie foods. He had the constant need, he was depressed, he had the constant need of chewing for stimulus. But they have high protein needs, and they do gain a tremendous amount of weight. And in respite of that, the weight they gain is not healthy because it's almost 100% fat. Because if they only have their arms to work with, you need the exercise and the diet to create muscle. So their lower limbs atrophy, and as that muscle atrophies, their metabolism needs go down. So depending on where their injury is. But they often, depending on the energy, they have no bowel motility because they just don't have it. So if you have an injury like here and you can only use your arms, then you have no feeling and your metabolism for your bowel motility is very limited. And therefore they need a lot of water and a lot of fiber. But how do you get that in them? You have to think outside the box by offering things like bran flakes, bran muffins, things that actually taste good, and yes, you can make bran cookies. So they really need to understand and looking at them, and you can assess their calories when they first come in, and some of them need 3,000 calories a day. But a month into it, they need to be reassessed because if they continue to eat 3,000 calories a day, they won't have good outcomes because if you've ever gained an enormous amount of weight at one time, it's like carrying around a lug. So they can't rehab effectively if they're carrying on another 50 pounds. And many times they're not able to understand that because their brain function is very poor. They cannot connect the dots. So a lot of times you have to talk with them. So when we're going back and where does that leave us? We have clients that come to us in sometimes not the best nutritional shape, and it's a job to take care of them. So I suggest that every building have a nutrition at risk screen. There's been some miscommunication. Honestly, a dietitian does not need to see every resident in a nursing home. If you use a screen, you can use the dietitian's time more effectively because for example, the MNA screens out those people that need to be seen with a 98% probability. So the people that really need the assessment, about a third of them do not need one statistically. But we should be spending our time looking at our clients that are at nutritional risk. Those people with a low albumin, those people that can't feed themselves, not particularly someone that is from the villages that's eating 95% and doing great and they're ready to go practically a week after they get there. But I think that we are so used to doing everything the same way in long-term care, everybody gets an assessment, everything gets the same thing, that we need to start thinking, how can we use, because times will get tighter financially, how can we use the resources we have to be as effective as we possibly can? And that is one way. A lot of clients are admitted with protein calorie malnutrition. You should be working with your dietitian to look at that. If they've lost 30 pounds in the hospital and their albumin is low, they meet the criteria for that, and you don't want to take the tag to have it diagnosed or developed later. But I think it's important that we realize that what we do is feeding them and discharging. If you know they're going home, you should be working with case management on what are you doing to prepare them and their family to take them home, and how is that going to work. And it really should start not when, like it's in the hospitals, they start discharge planning like the day that you go, and that is not effective in the least. So we know that all the regulations are there. We have to take care of our clients. We have to feed them. We have to give them adequate calories, and we have to show outcomes. We have to keep them free of pressure ulcers. And we know our jobs while they're there to have positive outcomes. But what do we need to do when they leave? Well, we need to have a great experience for them, because you want them to go back to the villages or to another area in Miami and say, you know what, the food was great. I had a really good experience. I did have a stroke, But 3 weeks later, it was amazing. The food was fantastic. The rehab department was fantastic. And I'm back and I'm 85% where I was. I probably won't be able to play golf, but maybe in 3 months I can if I continue to do outpatient rehab and follow what I need to follow. So when you're leaving, you want to look at the care plan during the admission process, which is different than the interim process, and then you want to have a discharge plan of care. Several facilities that I'm aware of in various states now have accordion files set up for each common diagnostic that go home. I'll give you some examples. So they have nutrition, the dietitian and the diet tech or the CDM are continuously giving information during the admission process. And they're talking about things. Cardiac rehab, there's a program that's teaching how to read labels. And no, the dietitian does not do that all. She does it with therapy too. Occupational therapy is teaching them how to feed themselves again, but how to look at a label to see if it's the right kind of food. And they're working really well together as a team. So when we start looking at discharge, you have to meet the client where they are, and honestly, they don't know. So when they leave, most of them don't know anything about nutrition. They need written guidelines and they need education. While they're in your facility, let's say they come to you with cardiac disease. There is really no point putting them on a 1,200 calorie diet, salt-free, the food tastes like dust. You want something that tastes good. You want to teach them as they're going through that. You want to work with the dietitian and the dietary manager about giving them information about how to make healthy choices on your select menu. All your food should be healthy, not just the ones for them. So instead of using chicken McNuggets that have lots of salt, maybe it would be better to have a grilled chicken product. So health for everyone, but they don't know this information. So you need a team approach that talks about during the time, everyone should be in, when you're talking in care planning and rehab, nutrition really should be one of the focal points because if they don't eat well, they don't rehab well. So prior to discharge, there should be a team approach, and pay for performance is here, and it will require, because if you want, as things move along, we're going to see more and more that the hospital will have more accountability if they send them to you. You send them home in 7 days and they end up back at their hospital and the hospital doesn't get paid for it. How does that affect the relationship? Not good. And I don't really think that long-term care, because I do work outside of other states, it's not just Florida, I don't think that a lot of people have quite embraced this. And that's why I wanted to speak on this, is I think it's a great opportunity for you to be cutting edge. So by doing just a few things, you can avoid re-hospitalizations. A nutrition discharge plan is very important for those people going home. So I've got 5 minutes, got it. So the re-hospitalizations can certainly be avoided a lot. In fact, Kaiser Permanente had an 88% reduction in re-hospitalizations after discharge. So how did they do that? They had a nurse, when the patient was discharged from the nursing home and the hospital, they gave them their nutrition, they gave them their diagnosis, what the doctor said they had. Then they had a very generic sheet, and it was customized for the client, of what they needed to follow. And almost all of them are really similar. Less salt. It gave examples. It gave an example of a person with CHF that left and they chose to drink 3,000 cc's of fluid a day, and they had chips, vinegar chips with barbecue sauce and barbecue ribs. They were back in the hospital 72 hours later because they gained 6 pounds of water. On the other hand, the studies that they had of the nurse exiting with the client, the case manager, and introducing nutrition discharge plans, they had an 88% reduction in hospitalization. So it's a must. So you want to review education and goals with your client, and I see the way I'm working on a pattern for our clients that for each of the 5 diagnoses that are most common in a nursing home, you would have a discharge education plan that the dietitian would be giving, and upon discharge you would have it administered to the family by a nurse or case manager. Easy to read, everything needs to be in 8th grade font. So education is important, working with occupational therapy, and if they need adaptive equipment, leaving with that adaptive equipment, easy to understand. But here's what I really wanted to talk with you guys a lot. Everyone in this room pays taxes, so do the residents. Nobody in long-term care that I know of is effectively utilizing our community resources like they should. Meals on Wheels is a fabulous program. It's in every single solitary community. Is the food like what you're going to get here? No. But it is a meal for someone that doesn't have enough strength to prepare their own food. It's also a visitor that says hello. There are many other nutrition programs, the Elderly Nutrition Program, Meals on Wheels, Congregate Meal Centers, and they do provide a dietitian to help educate the client. It's a requirement. And they also provide in-home meals and congregate meal centers. Meals on Wheels is proven a meal a day or any kind of meal, even if they're wealthy and they can afford a 30-day. Many of these companies now, you could call them up or email them, order 30 days of meals, and they drop ship them frozen, stacked. Put them in the microwave, 10 minutes later you have a meal. If you're weak, that could be a huge, huge asset. It should be part of your discharge plan to let our customers know about that. So by having that, you can keep readmissions away. Here are the list of government agencies that are universal. They're federal and state that you can access to plan how your residents can get better nutrition in your facility and at home to make a difference. Thank you. If you have any survey problems, call us. And we have a new service that we have rentable dietary managers, and if you need one, call us. Thank you.